So last time we were talking about mechanisms of action for our behavioral health meds. Again, how do they work to fix depression? Exactly, we don't really know, right? We do know that increased levels of serotonin and norepinephrine in some cases, depending on the medication we're talking about, but there's probably some downstream effects, probably pretty complicated. We still don't have a good unified theory for why that works. The first set we're going to talk about, and again, these are going to be used less frequently, mainly due to drug interactions and side effects, food drug interactions as well, as you'll see. But these are the monoamine oxidase inhibitors. These are going to prevent the breakdown of serotonin and norepinephrine such that more is available to be released into the synapse, and thus it should be activating those receptors that have whatever downstream effects that fixes your depression. So for instance, like Hyperemia was one of the first ones we had, and it was actually a tuberculosis med that we were giving that actually we found that, hey, these patients aren't so sad about their tuberculosis anymore. So they seem to work. So from then they decided to kind of develop these further, and this is where we get things like phenelzine, isocarboxazid, and then tranylcypromine. These are the three main ones we'll mention here. The big deal with these is that they're irreversible inhibitors of monoamine oxidase, which means that even if you stop the medication, the effects can persist for up to 2 weeks afterwards until you regenerate that enzyme, which is important because if someone stops it and you think, okay, well, the drugs, I'm not taking that drug anymore, I can add on something else, you will see interactions that can still occur for those few weeks afterwards. So that's an important thing there. As I mentioned, these are the phenelzine and tranylcypromine, probably the two most common ones you'll run into if you do. We've already talked about things like selegiline and rasagiline before in terms of Parkinson's. The big difference is that those for Parkinson's are specific for monoamine oxidase B versus these are going to be non-specific. They work on A and B in those cases there. But the nice thing is interactions are going to be pretty similar between the two. So if you remember things like selegiline back from Parkinson's, you'll remember a lot of stuff about these drugs as well. So things like postural hypotension is going to be a big deal because you can't necessarily regulate things like your norepinephrine as well, such that you may have issues from sitting to standing position. You'll typically see that sexual side effects are a very common thing with most of these antidepressants. We'll talk about one drug that is going to be better for that in terms of something you can maybe switch your patients to, but it could be just like they don't want to have sex anymore, or maybe they can't achieve climax, or whatever happens. It can manifest in different ways there, so you do want to be aware of that, because again, can that worsen someone's depression? Yeah, absolutely, right. So that's something you want to be considerate of. And then the really big risk with the monoamine oxidase inhibitors is this hypertensive crisis, and this is usually going to be related to a tyramine reaction that you'll see there. And if you recall the tyramine reaction, what kind of foods were usually involved with that? The bougie foods, like what? Aged cheeses, red wine, fava beans, all that nice stuff. Again, probably not foods that some of your patients might not be eating. I can't imagine how many people are drinking a nice Chianti in Putnam County, where I come from, but it could happen, right? Anyway, but you'll find that if you were to add this on with other medications that enhance things like norepinephrine, it can definitely be really synergistic, and so you have to be really worried about that. Has led to stroke, MI in the past, but fortunately we don't use these drugs too much anymore, mainly due to the fact of the interactions, the side effects, etc. We have newer agents that are going to be a little bit safer in terms of that. But again, just some of the medications you might run into, or foods that you might run into that can cause this reaction. Other drugs that can similarly cause this propensity to cause like a hypertensive sort of reaction would be other things like amphetamines. We'll talk about those when we get to the ADHD medications. Even things like cocaine, decongestants like Sudafed, any of these could cause a synergism there, leading to that really big increase in blood pressure. So from there, we move into the TCAs, and this is certainly a class of drugs you'll see much more commonly, not as commonly used as for depression anymore, but you'll see it's used for a lot of other things like neuropathic pain. You'll see it used for sleep. You can even use it for things like bedwetting. We'll talk about why that is in just a moment here. But the TCAs, they are actually derived from class called the phenothiazines, which are antipsychotic agents we'll talk about later on. These work by blocking reuptake of both serotonin and norepinephrine. Okay, so that's their main mechanism for depression, but you're going to find that they have a host of other effects that they have, which makes them inherently pretty dangerous drugs. So these are drugs that if I hear like there's a TCA overdose coming into the ER, I'm pretty worried about that patient because these drugs can be quite dangerous. Why is that important for treatment of depression? Yes, they get suicidal, right? So that's a risk inherent with all of the antidepressants, that you could see increased suicidality. So if someone takes a handful of these meds, I'm pretty worried about that patient. If someone takes a handful of their SSRIs, not nearly as worried. So that's why we have moved to the SSRIs, because they have a much wider safety margin for depressive patients, for anyone really, right? So here's some agents you'll find in this category, including things like amoxapine, amitriptyline, which is probably far and away the most common one that I've run into, or Elavil is a brand name there. Things like dicipramine, doxepin, nortriptyline. You can run into any of these. And in fact, back in the day before PAs and NPs in Florida could write for controlled substances, these are frequent agents that people would prescribe for sleep because you're going to find that they are quite sedating in terms of their actions. And so we'll look at why that is in just a moment. So they have strong anticholinergic effects. You're going to find this is going to lead to a lot of side effects you can see there. So remember the anticholinergic mnemonic that we use here. So things like mad as a hatter, blind as a bat. So why do you think, based off of this, why do you think it would be good for things like bedwetting? Dry as a bone, right? So you can cause urinary retention. Also, it can help out getting you to sleep, and maybe you're staying asleep. So we'd use this for children potentially have bedwetting issues. This could lead them to hold on to that urine till the morning potentially, right? Also be aware they can do things like blocking sodium channels on the heart, leading to arrhythmias. This is also a really big risk, and oftentimes why patients may die from a TCA overdose is due to the cardiac issues. Not only that, but also you'll be tachycardic due to those anticholinergic effects. They will also do things like blocking alpha receptors, which will cause vasodilation, leading to hypotension, which is also pretty significant in these patients here when they overdose on this. You also find pretty big sedation here, weight gain, sexual dysfunction, pretty typical for most of the TCAs, as we've already said. And again, maybe that sedation is a good thing if you're using it for sleep, but we'll talk about sleep drugs probably at a later date and some of the caveats with that. But anyway, so again, they're good for depression from the norepinephrine, serotonin reuptake inhibition capabilities, but it's all these other side effects, all these other effects they have on different receptors that lead to a lot of their issues, which is again why we don't use them quite as often. So that then brings us to the SSRIs, and this is sort of your gold standard go-to antidepressant medication for the most part. These are very specific in that they only work on blocking reuptake of serotonin. That's the only transporter they're going to be working on. And again, these are going to be first line for major depressive disorders. You'll see it's also first line for chronic anxiety issues, things like that. Much more tolerable from a side effect profile, and also much, much safer in overdose. Agents that fall into this category include things like citalopram and escitalopram. So you know those two are chemically related to one another, right? Which one's the racemic mixture? Remember, racemic means it has both left and right-handed molecules on there, so it'd be the citalopram is going to be the racemic mixture. Escitalopram would be just the left-handed version of it, right? Then you have things like fluoxetine or Prozac, which is probably one of the first ones that was out on the market, fluvoxamine, paroxetine, and then sertraline. So because they have such a low affinity for all these other receptor types, this is what makes them much preferable to the TCAs, as we mentioned there. They have less weight gain associated with that. However, most commonly you're going to run into things like GI disturbances for these patients. Sexual disturbances is still fairly common. Things like headache and insomnia can occur as well. So big things to remember with your SSRIs. And do you think compliance is an issue with patients with depression? Why? They're depressed, they don't feel like it, they don't want to take it, right? So you'll find that there is a strong discontinuation phenomenon that occurs with SSRIs. They get a lot of rebound symptoms that occur here, and that can include a lot of anxiety. They may have a lot of insomnia associated with this. Their mood is going to be pretty ornery. You guys familiar with that term, right? Term ornery. It's kind of a southern kind of thing, but they're cranky, right? So typically we want to make sure that patients will taper off of their doses when they are on SSRIs if they want to come off of them. Other things you could do potentially though would be to use something with a longer half-life, or if you have something that has active metabolites that once broken down still have serotonin reuptake blocking capabilities, that can also be pretty beneficial. So for instance, like fluoxetine is nice from a discontinuation standpoint because it will have a nice taper to it versus levels of things like citalopram will drop off pretty precipitously. So from that standpoint, that may be better for patients who may have compliance issues, which these patients may have as part of just their disease state, right? You'll find that for a lot of patients, especially with more kind of chronic anxiety issues, that these will also help out with those symptoms in a lot of cases. For some patients, they may just not respond very well to it. It may actually worsen that, so that's something to note. And then this QT prolongation can be an issue with specifically citalopram and escitalopram, so you do want to be wary of that. It's also important when you're starting to mix these with other medications. It can also prolong QTs, like some of your antipsychotic medications and other things that could also be causing issues there. So one thing to watch out for. So as I mentioned, nearly all of the antidepressants will have this black box warning for suicidality. It's not just the SSRIs. This is sort of a an effect that can occur with any of the classes we've mentioned here. And so they note this in particular for adolescents and children. Does anyone know why they would be more likely to cause or to commit suicide? What do you think? Not really. Yeah, so that's another caveat, is that the SSRIs and any of the antidepressants take a few weeks to kick in. The thing though, and I guess kind of one of the best theories I've heard on the subject is that typically, you know, if you want to commit suicide but you're really depressed, you don't really have a lot of energy to necessarily act on those thoughts. You're just kind of sitting there, it's like, I'd kill myself, but I just don't feel like it, right? What happens though is that you kind of get a little bit of extra energy when you start taking these SSRIs, and that may start to kick in a little bit before you really get to helping a lot with your depressive symptoms. So they may have more energy now to act on those thoughts, and that's why they think that they may be at increased risk for suicide, right? So that's a risk. Just be aware of that. Make sure that the patient and family members are aware and what to look for. What would you do if they did have those thoughts of committing harm? Well, what do you tell the patient to do? Go to the ER, right? So again, just go to the ER to get yourself taken care of. Call 911, especially if they've done anything already. But yeah, just make sure they're aware of that. Hey, if you start feeling these thoughts, just come to the ER, we'll get you taken care of, right? Again, that term, that increased energy, is called akathisia, and that's something that we'll talk about more when we get to the antipsychotic medications a little bit later on. But that's another good term to talk about, kind of this restlessness they can develop as a result of these medications here. Next, after the SSRIs, and we had the SNRIs, and so these look kind of similar to the TCAs in the fact that they block reuptake of serotonin and norepinephrine, but the nice thing here is they don't have all those other ancillary effects, right? So they don't block alpha receptors, they don't block muscarinic receptors. They're very specific just for serotonin and norepinephrine. You'll see these being used a lot for neuropathic pain issues, things like fibromyalgia and post-herpetic neuralgia, things like that. These are going to be things that can be beneficial from the norepinephrine effect. We've kind of mentioned that before. So things like venlafaxine, desvenlafaxine, duloxetine, which is a pretty common one that I see, milnacipran, and then levomilnacipran. There are probably some more that have come out recently. Again, this is a pretty fast-paced set of drugs here where there's a lot of new ones coming out because it is, you know, a pretty big money maker as time goes on. So biggest things you're going to see with these drugs, because of that additional norepinephrine effect on top of the serotonin effects, you can expect to see a few more side effects than your SSRIs. So more nausea, more GI disturbances. You may see things like increases in blood pressure, right, because of that norepinephrine. So it may not be great if you have patients with uncontrolled hypertension potentially. Insomnia, things like that can occur here. So just be aware that those are typical things you would see due to the extra norepinephrine effect that you may not see with SSRIs as much. There's a few here that sort of mixed serotonergic agents or mixed serotonergic actions. So for instance, we have things like trazodone, which are going to block 5-HT2 receptors in addition to blocking reuptake of serotonin. I typically will find these are used maybe as more second line, maybe third line if patients have not responded well to an SSRI or maybe an SNRI. One notable thing with trazodone, which I probably see most commonly, I see this used a lot for sleep because it's a non-narcotic agent. You can prescribe for sleep because it does cause a lot of sedation. It also blocks alpha-1 receptors, so you can see hypotension. And another thing that's kind of unique to trazodone, it actually can cause priapism, which is, what is that? Yeah, basically it's an erection that persists, right? So even without any kind of stimuli to cause the erection, and that can occur. And I've actually seen it occur in a few overdoses for trazodone. I had a patient where they were interviewing them, and there was like a med student who was examining the patient, and they're all of a sudden like, "Why does this guy have an erection? Like, we're in the ER, middle of the ER, he just tried to commit suicide." And like, oh, that's the trazodone, right? So it's a very sort of unique effect there that you can see with that. Again, you're going to see, be careful if you're combining these agents with other things for sleep, because again, you'll find some synergism in terms of sedation, so be aware of that. So if they're on like a benzo, anything else for sleep, you want to be cautious in mixing these. Now, bupropion is kind of unique because it has a novel mechanism here. So instead of just working on, say, serotonin reuptake inhibition, this actually works on both norepinephrine and then dopamine. And in fact, we've run into bupropion before. Where do we see that? It's in the pulmonary section. Smoking cessation, right? Remember, it helps to kind of re-regulate or try to find a balance with that reward pathway in the CNS to try to help with those cravings. Well, you'll see bupropion also being used for depression as well. It can help out with that. So maybe if you have someone who's a smoker, this might be a good agent to try with them. Be aware that there can be some risks, though. One of the nice things about bupropion is that it is least likely out of this whole bunch we've talked about to cause sexual side effects. So if patients have had issues with, say, like an SSRI, this is maybe a good agent to try with them, okay? Other things to note about bupropion, though, is that it can have a propensity to increase risk for things like seizures and arrhythmias. So you do want to be cautious if patients have a history of any seizure disorder, any kind of cardiovascular disorder, arrhythmias. Like, definitely I would probably avoid using bupropion. This is another pretty scary one that I see if patients have overdosed on it. And again, it's fairly common. I see a lot of patients who are using this. So, have you guys ever heard of Serotonin Syndrome? You know what that is? It's a syndrome of serotonin, right? Basically, whenever you have medications that are enhancing serotonergic effects, so blocking reuptake, maybe blocking the metabolism of anything that can enhance it, you'll find when you start to mix these meds together that you can develop what they call serotonergic toxicity, or that can go into full-blown serotonin syndrome. So it typically has 4 major signs or symptoms you're going to run into. So typically they'll have some degree of altered mental status. They can be hyperthermic. They may have some autonomic instability, meaning they may be tachycardic or bradycardic or hypertensive or hypotensive, somewhere around there. And they also have this increased muscle tone. Usually it'll be clonus, especially if the lower limbs tend to be more affected than the upper extremities. And so it's one of those things where, what else do you think that would look like? A patient who's altered, they're hyperthermic, they may be hypotensive. Shock, it kind of looks like sepsis maybe, right? It could be an infectious thing. So this is typically something you want to rule out all other causes for. So make sure there's nothing medical going on. Make sure it actually is related to the actual drugs themselves. That's what I mean when I say diagnosis of exclusion. You never want to look at a patient and say, that's serotonin syndrome. You got to rule out everything else before you can actually say that that's specifically what it is. So this is most commonly seen if you are maybe seeing a tyramine reaction with a monoamine oxidase inhibitor, or maybe, say for instance, a patient stopped a monoamine oxidase inhibitor and then you switched them over to an SSRI immediately, right? Why would that cause a problem? Yeah, it takes 2 weeks for those enzymes to regenerate themselves. So you can see by mixing mechanisms there, blocking metabolism and then blocking the reuptake, you see a big increase in the amount of serotonin there in the synapse, thus causing those effects. So that's something you really want to be cautious with in these patients here. Again, typical things you find in these patients can even lead up to things like rhabdomyolysis. If the muscles are too tense and they start to break down over time, it can be an issue. So typically, we'll just help to manage those patients supportively. We'll try to cool them down. We can use things like cooled IV solutions. We can use evaporative cooling, where you kind of spritz down the patient with water and put a fan on them. A lot of things we can do there. And then actually a drug that may be helpful here to kind of reverse some of these effects would be cyproheptadine. There's actually an antihistamine, which you could use for seasonal allergies and things like that, but it also does block some serotonin receptors. And so this may be something you would use if the patient, you were pretty sure it was serotonin syndrome, could not get the symptoms under control. You could introduce cyproheptadine, and that could help to reverse some of that. So, as I mentioned, it's good to consider using drugs with longer half-lives because they will help out if the patient is unlikely to be compliant with your medication. And again, you're going to find that there's not one gold standard like SSRI to go with for every single patient. You're just going to have to see how they respond to it. And just because they don't respond well to sertraline doesn't mean they're not going to respond well to, say, citalopram, right? So you can kind of switch around within the class and see what they're going to have the best because it's not necessarily the efficacy we're so thinking about, because again, it takes a few weeks for the efficacy to kick in. It's more the side effects the patient will get immediately, right? So usually you're picking based off the side effect profile. But be aware if that patients have hepatic dysfunction, they may hold on and to accumulate the drug, and that can also lead to serotonergic toxicity potentially. So in terms of drug interactions, a lot of the TCAs get extensively metabolized through CYP enzymes, so you do want to make sure you're checking and doing your interaction checks before you initiate a new medication for these patients, because there could be an interaction you need to watch out for, in which case you do want to start at a lower dose and then titrate up to see how they're responding to it. And then there could be some protein binding interactions you want to be cautious with. So again, anytime you're introducing a new drug, just look it up, right? Make sure you do an interaction checker. Everywhere you work is going to have some interaction checker available to you. I've never seen a place that did not. So make sure you look it up. So as I mentioned, any drug that can enhance serotonergic effects is going to be a potential interaction here. So things like linezolid, right? We talked about that. What do you use linezolid for? Yeah, vanco-resistant bugs, right? So if you're like VRE or VRSA, right? But that has monoamine oxidase inhibiting capabilities too, right? So you can end up seeing those effects there. You have a patient in the ICU who may be on antidepressant, and then you start them on Zyvox, and you can see that interaction there. There's a dye, actually I had one case at the Poison Center that was a call from a surgery center, which we normally wouldn't get calls from. And basically they were using a dye called methylene blue to it actually gets uptaken into the parathyroids. And so the patient was having a parathyroidectomy. Surgeon was using the dye to help visualize the parathyroids better, so that way they could excise them. But that also has monoamine oxidase inhibiting capabilities too. And the patient was on antidepressant. They didn't screen for that, and then all of a sudden the patient developed serotonin syndrome in the middle of surgery. Oops, right? Not great, but we were able to, kind of walk them through it and make sure we kept the patient cool and make sure they managed their blood pressure, and they were able to get the procedure done in the end. This will interact with your triptans we talked about for migraines. This will definitely cause increase in blood pressure potentially due to the extra serotonergic effects. You want to be cautious with that. Anyway, big point is, especially when you're thinking about switching between different antidepressants, you want to consider using a washout period where if you need to add on an interacting drug and the patient doesn't have to be on the SSRI right now, or the SNRI or the TCA, you'd like to give them a period of time where they can wean off of the drug, and then before you initiate the interacting agent. That may not always be possible, right? If I have a patient who is on fluoxetine for depression, but they develop VRSA and pneumonia, I kind of need to treat that right now. So that may not always be practical. As I mentioned, with the QT prolonging agents, this is mainly escitalopram and citalopram. You'll see this from an SSRI standpoint, but anytime you're adding on other antiarrhythmics or maybe antipsychotics, which we'll get into later, those can certainly extend that out. So you would want to check an EKG if you did have any interactions there, right? Any sedatives you add on, alcohol, I mean, is it possible depressive patients might be using alcohol? Right, so that could be potentially adding on to that increase in lethargy and sleepiness, right? Benzos as well will do the same thing. So, has anyone heard of St. John's wort before? You ever had like it's a weird part to name, a weird part of the body to name after somebody? This is St. John's wort. It's the best one. No, anyway, it's a plant, and it actually has this compound in it called hypericin that actually inhibits monoamine oxidase. So in terms of efficacy, will this work for depression? Yeah, it will, right? So there's definitely some efficacy to it, but is this an FDA-controlled product? No, it's a dietary supplement, right? So this is something you want to make sure, if your patient's interested in this, you at least talk to them about it and make sure that they're aware of the possibilities. Make sure, would you want to use this with an SSRI? No, serotonergic toxicity is a risk there. So biggest thing you're going to know though is that this causes a ton of drug interactions, and that's mainly because it's actually going to be inducing CYP3A4 and also this pre-glycoprotein. So basically it's going to drop levels of any drugs that are going to interact with it. So again, you want to make sure you're having open and honest conversation with your patients, and if they'd like to try it, or if they have tried it, at least allow them to be honest about it. Don't want to be too judgmental if you're not really a big fan of dietary supplements, because if they're taking this and they don't tell you and then you add on something that's going to interact with it, that could be big trouble for the patient, okay? So just be aware of that. Other than that, it's fairly mild in terms of effects, side effects. Maybe good for more mild to moderate forms of depression. But what's the other caveat with dietary supplements in general? Yeah, you kind of don't know what you're getting, right? Just because it says it on the label doesn't mean anyone's actually verified that from an FDA standpoint. So because of that, you want to make sure they're at least getting the same brand, staying consistent with that, so that way they can at least get some consistency in the product.
Is there any control at all? Like in Europe, we have something that's called ISO. It's like a quality control thing. Does it not apply?
There's no good manufacturing practice standards for this stuff. The only time the FDA comes in is if there's a safety concern. So if there's like cases of liver toxicity or something, and then they can come in and make them take it off the market. The most often times you'll find FDA gets involved is based off of the advertising or the literature on there. So for instance, they can't say we'll cure depression.
Right.
It can say we'll help with your mood or something like that, right? They make much more general claims there. Even though we know what they're using it for, they can't necessarily market it for that, right? So you can't say like glucosamine and chondroitin, this is going to fix your arthritis. Like you can't say that because that's an actual treatment of disease. We can say it can support joint health, right? It can support mental health, right? Anyway, so generally you're going to start off with an SSRI, which when you start with doesn't really matter. Depends on what the patient's insurance will cover, what they can get available. Most often we don't like TCAs because of the increased side effect profile. But think about other concomitant conditions, right? Do they have neuropathic pain? Well, maybe adding on an SNRI would be a good one to start with, right? I typically will avoid MAOIs if at all possible, just because the side effect profile is not very nice, and also because of the food interactions there. But you may still see it, right? You may still see patients who've been on this. Maybe they've been on it forever, and that's just what works for them. In terms of treatment failure, you want to assess for compliance, right? But if you have a depressive patient who's not taking their meds, and you ask them, hey, are you taking your meds? They're going to say, a lot of times they'll say, yeah, I'm taking it like I'm supposed to. But they're not really. So not that they're always going to lie, but you know, there's a possibility, right? So assess for compliance, make sure they're actually using it like they're supposed to, and be aware that just because they fail one SSRI or an SNRI doesn't mean you can't switch within that same class. Because again, patients will respond totally differently to it depending on the situation, depending on how just they work to it. Sometimes you may actually find they'll need additional therapy. So for instance, if they have bipolar disorder, which we'll talk about in a little bit, you may need to add on things like lithium, or you may need to add on something like an antipsychotic. So you always want to check for those interactions there because they can be pretty significant. Any questions on depression? Okay, remember how long does it take for these drugs to kick in? Like 2 to 4, maybe up to 6 weeks before you really see full effect there. So just be aware, make sure you educate on that. Getting bipolar disorder. What is bipolar disorder? Yeah, so you have the extremes of moods, maybe you have depressive symptoms for a period of time, then you go to more manic symptoms, right? How can those manic symptoms manifest? Impulsivity, like what? What does that mean? Okay, gambling, yeah, so maybe like compulsive behaviors like gambling. What else? Shopping, yeah, maybe. Maybe my wife is manic. Every day I come back, there's always more Amazon boxes. Weird. What else? High-risk sexual behaviors, right? They have an easy time keeping jobs? They may not, right? Because they just don't feel like going to work. You know, remember, like these hypomanic episodes as well may be actually beneficial to the patient. They may feel pretty good. You know, maybe they clean up their whole house. I'm like, man, I feel great. Why do I need to be treated for that, right? A lot of times you're going to find these patients are difficult from a compliance standpoint because they don't feel like when they're in these manic episodes that they need any help. They don't feel like they need to be treated. And so you're going to find that's going to be a big issue. We'll see with some of these drugs here. But basically, you're going to find this is going to be a lifelong issue. Certainly, incorporating non-pharmacologic means is going to be helpful, but we're going to focus on the Pharm here because this is your Pharm class. Again, we don't know why this occurs. There's probably some genetic component to it. There may be an environmental component. We're not really sure, but we do know that the medications that we have, even though we use varying different mechanisms, they do tend to be effective in terms of stabilizing that patient's moods. When you hear mood stabilizer, this is basically what we're talking about. So, and surely, if you have a patient who's coming in and they appear to be manic, maybe they're having flight of thoughts, maybe they're not able to sit still in their seat, maybe they're having all these compulsive behaviors, rule out other things as well, right? So you want to make sure there's nothing going on. You know, is there any medications that could cause that kind of manic sort of effects? Like what if they're taking ADHD medications, right? Like amphetamines, that could certainly cause, any kind of stimulant can do this. Could it be cocaine that they've been exposed to? Could it be that they're withdrawing from alcohol? Could it be, there's all kinds of other drug-induced reasons for this. You want to rule out, but certainly things like electrolyte disturbances, infections, all of that, you want to watch out for. When I say hallucinogens, anyone know what are some agents I would be referencing there? Things like LSD or acid. Magic mushrooms, potentially, it's like psilocybin-containing mushrooms. Anything else? Meth is kind of, that one you don't see as much as in terms of like hallucinations necessary, but there's like there's one product called like DMT or dimethyltryptamine. So there's a lot of different agents that's kind of a big category. Things like mescaline, peyote, things like that will kind of fall into that category there. Anyway, so you'll find these patients, sometimes you will find them in a very acute manic phase. Sometimes they can be dangerous to themselves or others. So it's not uncommon you find these patients in the ER who are in 4-point restraints. They're trying to, fight somebody. They're trying to, they're very potentially dangerous, again, as I said, to themselves or others. So there may be acute phases you need to treat these patients in order to get them calmed down. And then there may be more maybe not as severe episodes that may be being treated for, but basically you want to prevent those recurrence of symptoms. You want to get them under control initially and then help to maintain that by using these mood stabilizers here. Make sure you're trying to eliminate any concomitant substance abuse to go along with this as part of that compulsive behavior. There may be alcohol or other drugs involved. Try to help with that because that only exacerbates their symptoms in a lot of cases. So therapy is going to be pretty individualized, mainly because different patients will have different frequency of episodes, different symptoms when they have these episodes here. But for the most part, you're going to find they typically need to be on some kind of mood stabilizer, usually for a lifetime. That includes things like lithium we'll get into. And then you also want to consider as well the depression, as you know, do they have depressive symptoms that need to also be treated? So it's not uncommon to be on an SSRI plus a mood stabilizer to help control this bipolar disorder. You'll see a lot of these meds used as well. I see this frequently in kids that have like oppositional defiant disorder or any kind of like really aggressive behaviors. You may also see them using these mood stabilizers as well. So the first one I want to talk about is lithium, or lithobid. So you used to be able to find actual cocaine in Coca-Cola back in the day, and you actually used to be able to find lithium in 7-Up back in the day. So again, it's like the soda would lift your spirits because it's helping out stabilize your mood. So anyway, so it's been around a long time. In fact, lithium's been around as long as Earth has been around, right? Because it's a metal that's just in the soil. But basically what you're going to find is that, again, we don't know how it works. There's probably some complicated mechanisms using modifying things like IP3 and different things like that. But the main point here are going to be the kinetics and a lot of side effects you can see with this medication here. So lithium itself, if you look on the periodic table, I don't have to look because I had the whole thing memorized. I'm just kidding, I don't have it memorized. But if you look on the periodic table, you'll see that lithium and sodium are pretty close to one another, actually right next to one another in terms of their place on the periodic table. What that means is that they get treated very similarly in the body. The body can't tell the difference between lithium and sodium. So if you're in a state where you're trying to pee out a lot of sodium, guess what? You get rid of a lot of lithium too. If you're in a state where you're holding on to sodium, guess what? You're going to hold on to a lot of lithium. And that's going to be a source for a lot of drug interactions we're going to see here. And lithium, either with a chronic or an acute overdose, you can see a lot of toxicity here. So this is something you want to be aware of and make sure you don't have any interactions going on. Anyway, so you'll still see this used pretty frequently, maybe as a backup. For a long time, and this is just like was first line therapy for bipolar disorder. But now because of the toxicity profiles, and we have some other agents that may be a little bit better tolerated, you're kind of moving away from this a little bit. But certainly these can help to prevent those manic episodes, maybe risk for suicide associated with that as well. However, this does require therapeutic drug monitoring, so you do have to be really cautious with this one and make sure you're looking at it. And actually, if you look at the levels, notice how it's in milliequivalents per liter, kind of similar to how you like measure sodium, so that kind of makes sense. It's kind of like an electrolyte in that case. But also be careful of these patients. They don't abruptly discontinue their medications, but is that a possibility with someone with bipolar disorder? Absolutely. So you have to be really cautious with that. Again, if they don't feel like they need treatment, then they won't seek or stick with their treatment. You may find that these patients require multiple mood stabilizers, so this could be a backup agent you can maybe add on to one of the other drugs that we'll talk about here. So that's one thing to consider, is you may be on lithium plus something else to help control that mood. So many patients are going to develop side effects from lithium, and so this is a big reason why patients will stop taking it, is because of the side effects here. So usually you're going to find it's related to these peak dose effects, so a couple hours after they take the drug, that's when we're going to get most side effects here. So you can't see a lot of GI distress. Because it's an electrolyte, it's going to cause this osmotic diarrhea that can be associated with that for some patients. Muscle weakness, lethargy, things like that are pretty common. And even like polydipsia, what do you think would cause polydipsia and nocturia? Because your kidneys think there's an increased sodium load and it wants to get rid of that, and so it can go ahead and cause that, right? Or it can cause an ADH response, causing you to try to dilute out that extra electrolytes, and so it's going to try to get you to drink more. So that could be a big thing you'd see with that. So in terms of the chronic effects, what you're going to find here is that this fine hand tremor tends to be pretty common in a lot of patients. And again, this is just not even at high level. This can just be a baseline. It could be therapeutic, and they'll develop this. So you do want to be wary of that. Maybe beta blockers have been used in the past to actually help to blunt that a little bit. So that can be another med you'd actually add on. But again, can beta blockers cause depressive symptoms? Yeah, definitely propranolol as well, because again, it's very lipophilic, causes a lot of CNS effects. So you want to be cautious with that. One thing that also is unique to lithium is it causes this nephrogenic diabetes insipidus. Anyone know what that presents like? They're thirsty, but they're just peeing a lot. They're peeing like out very dilute urine. Basically, this is a case where lithium will make the kidneys not responsive to ADH, right? So basically, you're not putting in those aquaporin channels in the collecting ducts, and so you're just losing all that water. It's very dilute urine they're experiencing there, so they can get dehydrated. So this one you want to be cautious with. And actually, what's interesting, you actually treat this nephrogenic diabetes insipidus with loop and thiazide diuretics. you're like, wait a second, it causes you to pee. Why would you do that? It has to do with the sodium handling in the kidneys and helps to kind of reset that a little bit, so that way you're going to hold on to more of that water there. So I'm not going to get too much in the weeds on there, but just be aware that that's a unique effect of lithium causing that diabetes insipidus. Other things like nephrotoxicity can occur, and then even hypothyroidism due to the fact that lithium can interfere with actual thyroid hormone synthesis. That's one thing you can see that. Patients with hypothyroidism, what are their moods usually like? A little lower. Maybe it can worsen their depressive symptoms, right? So it's something you want to watch for. In terms of chronic effects, you can see things like acne and pruritus associated with this, some ataxia, slurred speech, and then even some cardiac effects you can see with more chronic use. And in terms of overdose, this is another one of those scary ones. Probably not quite as scary as the TCA, but I'm still pretty worried about these patients here. Seizures are a big thing we can see that can be very difficult to treat with lithium overdoses. And when I say acute or chronic, what do you think is the difference between that? Well, if you, I'm talking about when I say an acute overdose versus a chronic one, what does that mean? Yeah, so in the acute ones, someone just took a big old handful of lithium right then, right? Chronic means that they have been either on too big of a dose, or maybe their kidneys can't clear it as well, and so the levels are gradually building up over time. Which one do you think can be more dangerous? It's actually the chronic one can be scarier because it actually gives time for it to build up in the body and in the CNS, and so I'm a lot more worried about a chronic overdose, usually is unintentional, versus an acute one. So anyway, not going to get too much in the weeds on that either. Anything that's going to cause the kidneys to hold on to more sodium is going to cause the kidneys to hold on to more lithium here. So for instance, if you were to say give a patient an NSAID or maybe an ACE inhibitor or anything like that, you can actually hold on to more sodium, and then you're going to hold on to more lithium. So that can be a common reason for an increase in side effects or an increase in levels that you can see with that, right? I think it's fairly narrow therapy, as a narrow therapeutic index. You really got to be watchful for that. I had one time had a patient who was presenting, he'd been on lithium for years, no problems, but then he developed all of a sudden really nasty tremor. He's getting really dizzy every time he stood up, couldn't really walk straight. And it turns out he just got started on an ACE inhibitor a couple days beforehand. No one screened him for that because, again, his person who prescribed lithium is not the same person who prescribed the ACE inhibitor, and so then you cause that interaction there, right? So that's lithium. In other agents we're going to use, and this is probably going to be more commonly initiated first, are going to be some of our anticonvulsants. Nice thing about the anticonvulsants is what? We've already covered them, so you already know a lot about them, right? And in fact, you may see them being used more often for mood stabilizing purposes than for their actual anti-epileptic purposes. So the first one here is going to be Valproic Acid. I see this one used all the time for these patients. From a side effect profile, pretty well tolerated. Again, biggest things you're going to find some sedation. But what are some other things I'd want to monitor for with Valproic Acid? Pregnancy for sure. Yeah, could pregnancy be a risk for these patients? Why? High risk sexual behaviors, right? So, all right. So you're using unprotected sex, multiple partners, things like that. So that could definitely be a risk for these patients here, right? What else? Pancreatitis. What else? Hepatotoxicity, right? So you got to watch your LFTs for these patients here. So again, we're not really sure why it works to help stabilize their moods, but we just know that it does work, and so it's kind of good enough for us as it turns out. And again, it's nice because you also can have some synergy there. So I could use Valproic Acid plus lithium and get some additional benefits if one agent by itself was not working for those patients. That's kind of nice. As you mentioned, other things you can see potentially is this hyperemia. It actually has to do with a carnitine deficiency these patients can develop. And again, hyperemia actually presents with altered mental status, so it's kind of a neurotoxin. So you would want to be watchful for that. Anyway, again, yes, sir.
Would you still give them the cholestyramine?
Cholestyramine, why would I give that? What? Yeah, it's a different agent. Yeah, no worries. Anyway, so again, narrow therapeutic index, so at least you want to watch for these levels here. Also, if you're thinking your patient's not taking their medication, this is another good way to check for compliance. If they're level 0, guess what? They're probably not taking the medication, right? Carbamazepine or Tegretol is another common one being used here. What would I monitor for with Tegretol? Any electrolyte in particular? Remember, SIDH can occur here, so you would want to watch their electrolytes in those cases. Again, this one's working with that sodium channel blockade. And again, if a patient has bipolar disorder and a seizure disorder, these also are going to be really good because they can pull double duty in those cases there. Typically, I don't see as many patients start off on Tegretol, maybe as an add-on agent, but I see a lot more VPA being used kind of first line. Again, lithium is just kind of taking a back seat just due to the side effect profile, and the monitoring is pretty intensive. You already mentioned the SIDH. Remember, this induces CYP3A4, so you want to be checking for interactions from that standpoint as well. It causes a ton of drug interactions. And then Oxcarbazepine similarly could also be used as kind of a cousin to Tegretol. Remember, the SIDH is going to be worse for this one, but it doesn't have as many drug interactions due to not inducing CYP. So that's kind of one benefit for using Oxcarbazepine or Trileptal. Again, there's no therapeutic monitoring for Trileptal, which is also nice. You don't do as much monitoring from that standpoint. But you also can't check for compliance as easily as you could for something like Carbamazepine or Valproic Acid. Again, there's minor induction here, so CYP3A4, but it's not going to be as strong as with Tegretol, so that's why, again, you see fewer drug interactions, but you still may run into some, right? Lamictal, also being used fairly commonly. Again, Lamictal is nice because it doesn't cause as much sedation as you would see with some of the other ones like Carbamazepine or Valproic Acid. Again, useful as an add-on agent potentially. Remember, there's a big interaction between Valproic Acid inhibiting metabolism of lamotrigine, so you definitely have to drop your dose for that one if you're going to initiate these two together. So be watchful for that because it's a more common combination that you see, and a lot of people are not aware of that interaction. What's the big thing to worry about with Lamictal? Rash, all the way to Stevens-Johnson syndrome. Again, any new rash, you want to be really saying, hey, let's stop taking this and let's go ahead and get checked out. Right? Okay, so those are the main mood stabilizers you use for these patients. Let's talk a little bit about antipsychotics. We're going to get more into detail on that in the schizophrenia sections coming up next, but I want to talk about how we're going to use these agents here for bipolar disorder. Antipsychotics themselves, for the most part, tend to be quite sedating, right? So this is going to be good agents to start out with for patients who may be in a really acutely manic. I see this used a lot in the ER for patients who may be violent, right? So I remember there's this one patient, and a common one we use is haloperidol or Haldol. Anyone ever heard of that drug or seen it? So frequently you'd have these patients coming for these really acute manic episodes, especially the violent ones. You know, if someone's being really uncooperative, how easy is it to get an IV started? You probably can't, right? So frequently we need some kind of chemical sedation in order to get these patients under control. That way we can do whatever we need to do, get labs and whatever else. So anyway, so I had this one patient who was in the ER, I'll never forget this, because we were on rounds, it was like 7 o'clock in the morning, and this guy was like just screaming his head off, you know, at the other end of the ER. And he's like, I'm about to go off here, I'm an atom bomb, I'm about to blow up. Just like screaming. And then of course he's in 4-point restraint, so he can't go anywhere, but he's just screaming, fighting. And then all of a sudden he's like, I'm going to get every one of you people. And then, so that was after they gave the Haldol and the Ativan to him via IM, and slept off the rest of the morning, right? So it's one of those things where frequently when they're that agitated, you have to get them under control, and this is where some chemical restraint or chemical sedation can be really useful here. So a lot of our antipsychotics actually work through blocking dopamine. I'll show you some more detail on that a little bit in just a few slides. But basically by blocking these dopamine 2 receptors here, you're able to help deal with some of the symptoms of schizophrenia, but also can help out in terms of helping with these very agitated patients who have bipolar disorder. Frequently you'll find that you may either use it as in those kind of acute settings, or you may be using it as an add-on to patients' mood stabilizer. So it's not uncommon you'd end up seeing something like aripiprazole or Abilify added on to something like valproic acid to help kind of control and stabilize that mood there. We'll talk about the long-term effects of these, but mostly you're going to find these tend to be more of a metabolic nature. So things like diabetes, things like hypertension, dyslipidemia are things you want to be watchful for when they're on these antipsychotics. The nice thing too, though, with a lot of the antipsychotics, or some of them, is we actually have injectable formulations that are long-acting. So if I talked about like depot drugs before, I say depot, what does that mean? You guys know like what a depot, like the Home Depot is? It's like a place that kind of store a bunch of stuff. So we have depot drugs that actually can be injected into the muscle, and they last for a really long time. So they'll actually last for the course of several months. So have you ever heard of like a depot shot for like birth control? Same principle, right? You inject into the muscle, it lasts for like 3 months. So we can do that for antipsychotics as well for some of them. And what's the benefit of doing that? Ensured compliance. They can't take the muscle out, so once it's there, it's there. And so that also can lead to problems. So you want to make sure that if a patient's going to have a side effect to it, they're going to be stuck with that drug for quite a period of time. So it's maybe not the first thing you start with, but see how they tolerate the drug, and then you can maybe initiate that. So in general, we're going to start off with a mood stabilizing agent here. So lithium, carbamazepine, VPA, I probably see VPA most commonly here. And then if they're having issues of insomnia, anxiety, or agitation, you can add on a benzodiazepine. So what are some examples of benzos we could use? Ativan, which is lorazepam. What else? Midazolam. So midazolam would probably, for the most part, lorazepam as well. You're going to see mostly more in the inpatient hospital sort of setting there. Certainly you'll see some oral options for lorazepam. Versed, though, is mainly just going to be injectable. You mainly use it in the hospital for the most part. What are some other ones we can use? Diazepam could be used. What else? Alprazolam or Xanax is another really common one. Clonazepam or Klonopin. Again, those can be useful for patients that have that anxiety, insomnia. Be cautious, though, if they have a history of substance abuse, because, again, these are controlled substances. You could be another risk for addiction. As I mentioned, you may need to start with 2 agents at the same time for those really severe manic episodes in order to get them under control there. If they're having an inadequate response, that's where you want to consider adding on a second agent, so maybe like a second generation antipsychotic or maybe an anticonvulsant. Any of those would be totally fine. So you may find patients on 2 medications just for the manic aspects of it, and then they may also be on something like an SSRI for the depressive symptoms. Any questions on that? Yes, sir. Not necessarily. I would probably use it as an add-on for that. Like, let's say I had symptoms of schizophrenia, they've been diagnosed, and then I might consider doing that. Yeah. Again, any of the anticonvulsants, really any of them, you can try it out and see how they're going to respond to it. There's no real rhyme or reason. I think I just see Valproic Acid is just probably most favorable from a side effect profile. Not necessarily. You know, if it's it depends if the patient, you know, for instance, if maybe. I think a good case. Like, for instance, you know, if they still have a job and sedation is a big issue, then maybe we can consider using Lamictal first. It's going to be least sedating, so it could be something to consider, right? All right. So if no other questions, let's do a 10-minute break. We'll come back and then continue on. If one discontinues and restarts an SSRI, are the effects still the same, or do TCAs have a faster onset of action? So they'll all have the similar onset of action in terms of working for their depressive symptoms, so still a couple of weeks in those cases there. But again, side effects can show up immediately. And again, if one discontinues and restarts an SSRI, are the effects still the same? I guess I don't know what that's referring to specifically, like side effects, or but the person wants to remain anonymous.
Because I've heard that if you discontinue and restart, it's not as beneficial for the antidepressant effect.
Oh, I've not heard that specifically, so I'm not familiar with that particular effect. I don't know. Because you presume that it would have similar effects once you restart it, but I'm not aware of anything. Yeah.
I met a patient who was on lithium for his bipolar disorder for a very long time, and his kidney function was progressively decreasing. And he swore by drinking nettle tea. Have you ever heard of that? Is that
nettle tea specific?
Like, off on his own tangent.
I'm not aware of nettle tea being anything that was using it to help with his kidney function, or.
He said that the nettle tea that you drink twice a day helped preserve the current function of his kidneys and it stops it from decreasing even further.
I'm not aware of that. He may believe that. Maybe there's some mind over matter. I don't know.
I think his mind over matter is what was going on.
Perhaps.
It was a placebo.
He's willing his kidneys to work better, right? I do not know. If you take an antidepressant drug as a sleep aid, would it ever have an effect on depression? So in some cases, you may find patients, so like say for instance, you're taking more sedating antidepressants like a TCA. By taking that at nighttime, because you get most of these meds you're taking one time daily anyway, that can help out with sleep and then also help out with the effects of depression as well. So that could be a potential strategy you'd want to go with there. But keep in mind things like SSRIs, they more tend to cause insomnia in a lot of cases. So it depends on which ones you're kind of going with from that perspective. So, okay, very good. So let me continue on. So getting into your antipsychotics, it's nice covering behavioral health stuff because you can kind of start to diagnose things in your professors. So like narcissistic personality disorders, or things like that. Most typical with the professors. But getting into our antipsychotics. So have you covered anything about schizophrenia so far? So schizophrenia mainly is going to be due, we think, to this dysregulation of dopamine in different parts of the brain. And so basically you see in some places you'll have hyperactivity of dopamine, and in some places you'll see underactivity of dopamine. And so our main goals are to try to get this sort of re-regulated with some of the medications we're going to use here. So for instance, I'm not going to ask you specifically where it's underactive or overactive on a test question necessarily, but I want you to kind of know how some of these symptoms are manifesting and how the medications kind of help out with this. So for instance, when you hear about schizophrenia, like what do you kind of think about? Like what do you... Delusions, I mean delusions of grandeur, like I'm a really funny professor, right? What else? They may have things where, you know, they have a lot of like auditory hallucinations that may influence them to do things potentially, right? So there could be risk for that. There's also going to be some other symptoms we'll talk about, things like negative symptoms as well. So when you talk about things that are there that shouldn't be there, like the auditory hallucinations and delusions of grandeur, we call those positive symptoms. Those are typically the more like kind of life-threatening, potentially dangerous symptoms we'll talk about that we want to get under control. But there's also a lot of like negative and cognitive symptoms. So frequently you find these patients may not get a lot of joy out of things. They may not have a whole lot of like motivation to do things. They may just kind of like sit around. They have kind of a flat affect. That's going to be more part of those negative and cognitive symptoms we'll talk about as well. But everyone kind of thinks about like, you know, psycho or something like that, you know, they're killing somebody, but that may not be how it manifests necessarily depending on the patient there. But anyway, we'll also find that serotonin is going to be playing a role here, and that'll be really important when we get into our atypical antipsychotics. So, and again, looking at these patients, how they present, basically they can kind of create this false sense of reality for themselves. So you get those hallucinations like hearing voices. Typically it's more auditory. You don't see a lot of visual disturbances necessarily. They'll have these ideas of influence. They feel like they're being influenced to do things by external causes. Usually those voices are telling them to do something. And as I mentioned, the affect may be pretty flat or maybe kind of inappropriate, may respond. They may start laughing at in inappropriate times and things like that. You also tend to find that their personal hygiene tends to suffer. So maybe they can't keep a job very well, they don't maintain their relationships, they don't shower much, you know, things like that.
How do you like confirm that they're actually having hallucinations? Because couldn't they just be faking it?
Perhaps. You got me. Yeah. Again, this is where things like the DSM-5 will have whole criteria where you can actually go through, and they'll have different criteria they have to fit in order to get this actual diagnosis. But can someone fake it really well? I mean, I can fake having ADHD and get amphetamines potentially, right? I could fake pain and get pain medication. So there's always a risk, but it's hard to say. And if you can figure out how to tell if a patient's lying, I would like to know that as well. That'd be nice. We usually just assume if their lips are moving, they're lying. That's usually a pretty good, safe bet for in a lot of cases. But anyway, you're also going to find that they don't understand the importance of treatment because they don't feel like there's anything wrong in some cases. And so a lot of decreased medication compliance, a lot of hospitalizations for these patients as well. And you're going to find that there's a high rate of substance abuse to go along with this. So a lot of nicotine, a lot of ethanol use, illicit substances are going to be a frequent co-ingestion or co-presenting sort of problem with a lot of these patients here. So as I mentioned, we talk about the positive symptoms, which are things that are there that probably shouldn't be. So like that kind of paranoia, hallucinations, things like that. The negative symptoms, though, are things that should be there but are not. So for instance, they have that flat affect. They have anhedonia. Anyone know what that means? You don't really find joy in anything anymore. It's also the name of my emo band back in high school. Avolitions, they don't really, you know, are not going to have like motivation to actually like do things or enact on things. Alogia, anyone know what that is? If you can't come up with words, you just had alogia right there, right? And then that cognitive sort of symptoms, right? So impaired attention, memory, etc. So we're going to find that we'll have medications that are really good for dealing with the positive symptoms, but they may not be so good at helping out with the negative and the cognitive symptoms. And this is going to be important if they're having like an acute issue, right? If they're acutely violent or something, you know, dealing with those positive symptoms is really important. But chronically, you're going to find that we also want to deal with the negative and cognitive stuff too. And so we're going to see that have another class of meds that are going to be able to help out with that. So you're going to find that most patients are going to require some degree of pharmacologic therapy, but compliance is going to be a really big challenge for a lot of these patients here. It's where a lot of those depot forms of these antipsychotics are going to be helpful here. And you're going to find that everything needs to be really kind of individualized for the patient to see like, okay, well, you know, what kind of symptoms do we have here? How do we need to manage this? You know, what kind of support can we provide for the patient? And in some cases, you may need up to a full 3 months before they kind of get really kind of settled in on the meds. And again, this is another class of drugs that are going to see a ton of side effects up front, but the actual full therapeutic effects may still take a while to really be realized. Another big thing we would like to do is try to decrease the amount of rehospitalizations that occur. So frequently these patients may be brought in because like family members are calling 911 on them, or like maybe police officers are involved bringing them in. A lot of reasons for hospitalization for these patients here. We used to have what we call the fishbowl, like when I was in fellowship during in the ER, we had this one room where there's like glass windows on either side, and that's like just where you put all the Baker Acts and all of the psych patients back there. And it seemed like a bad idea at the time because they just kind of egg each other on in a lot of cases. And again, this is one of those things where you want to try to like calm them down and like kind of keep stabilize them, but it can be difficult in a busy ER because I don't know how many of you have been in an ER, but is an ER a very calm place? Not so often, right? But anyway, I would like to decrease obviously the recurrent episodes if we can, and kind of stabilize them and keep them from having those symptoms come back. So getting into the first generation antipsychotics, the main mechanism you're going to see here is blocking D2 receptors. Okay, so they're blocking dopamine, and this is really important for causing or helping to decrease the positive symptoms. Okay, so basically that overactivity in the nucleus accumbens is going to be diminished such that it kind of goes back down to somewhat normal levels there. So this is going to be good for helping out with the the paranoia, the hallucinations, all those things. If someone's potentially violent or harm to themselves, like that is what we're trying to deal with as positive symptoms. The negative symptoms, though, and the cognitive stuff actually takes a bigger hit here. So I don't know if anyone's ever watched the movie A Beautiful Mind with Russell Crowe. That's a story about a guy who has schizophrenia, and actually if you look at the medications he takes during that, it's actually pretty true to life. He's on a lot of these early antipsychotics, and I mean, you'll find these patients that are on these will frequently be completely zonked out, like they're just sitting on the couch, they're not really moving a whole lot, and that'll actually make sense too. We look at some of the other ancillary effects from these meds as well.
So what's the risk for Parkinson's? Because don't make these drugs cause Parkinson's?
Absolutely. We're going to get right to that. Thank you for that segue. So let's look at the side effects, right? Because we're blocking dopamine, you can have these things that you would expect to see. So for instance, like hyperprolactinemia can be a common occurrence here. So basically you can develop things like gynecomastia, menstrual irregularities, because you're blocking dopamine, so prolactin actually goes up in levels there. The decrease in dopamine activity is also going to lead to very similar effects to Parkinson's. So for instance, remember how we have those tremors at rest, how we have that pill rolling, difficulty initiating movement, all that same stuff can happen here, right? And in fact, those are going to be called extrapyramidal side effects, okay? Those are going to be things like acute dystonias that can occur, where basically they'll come in kind of a locked in, like they can't move their arms, or maybe it can present in the face. We had this one patient that came in one time. Did I talk about the family who came in taking diazepam, taking Valium? So there's a family as a mom, a dad, and a probably early 20s-ish guy, and what they thought they were doing is they were buying Valium off of the street, right? So they're buying it from a dealer, in Valium, diazepam. How would you expect someone to present who is taking diazepam? Pretty chilled out, maybe they're a little sleepy, maybe stumbling around a little bit. Well, they came in, and all three of them were like, kind of locked in like that. And you're kind of like, well, this doesn't look like diazepam. I mean, if anything, you'd expect that to relax the muscles, not tighten them up, right? But it looked like an acute dystonic reaction. And again, that's how patients with more progressive Parkinson's can look as well. They get kind of locked in like that with those dystonias. And so what had happened actually was, when they were able to get the pills, they actually looked identical to haloperidol. They had the same markings as haloperidol, which is one of these antipsychotics. So what they thought they were buying was Valium. What they ended up getting was haloperidol, and causing an EPS symptoms to manifest there. So again, moral of the story is, don't do drugs. Don't buy drugs off the street, or at least make sure you can properly identify them if you're going to do that. And the family that does drugs together, they stay together, as it turns out. So anyway. But yeah, you'll get that tremor, you get that motor rigidity, all of that's pretty common. And then as well, you can see this dystonia, you'll see this a lot with like the face and the neck muscles. They can get that acute dystonic reactions there. I actually had one case, you guys ever heard of the term opisthotonus? If you Google that, but you probably don't know how to spell it, but because it's a pretty hard word to spell. But opisthotonus is this like extreme back arching that occurs, where basically all the muscles of the back are all contracting on one. There's like this really famous painting of a guy who is having opisthotonus. I actually had a case where there's a 10-month-old. The mom, I guess, had meds lying around, had an antipsychotic. Kid got into it and was developing this very severe dystonic reaction. The whole back was all contracted, as you might imagine, pretty painful. And we actually ended up having to treat that in the ER. So I'll tell you how we treat that a little bit later. But again, these are common things you would see due to that lack of dopamine activity. So other things you're going to find, they can develop what they call akathisia. I mentioned that before as something you may get sort of in some minor, kind of a minor effect of the SSRIs, but certainly a lot bigger here with the antipsychotics. So this severe restlessness, agitation, I kind of liken it to having ants in the pants, where you just can't really sit still, like you just feel like you want to jump out of your skin. Has anyone ever felt like that before? No? No one's ever taken antipsychotics? I guess. Anyway, point being is that they can get this anxiety, they can get agitation associated with this. So it's something you'll see with this dopamine antagonism. And then chronically, this is also something we would worry about in the long term. So say over the course of years, these patients would be on these medications. They develop what they call tardive dyskinesia. And so this is going to be a thing that was a big problem with a lot of the first generation antipsychotics, but that's all we had to treat schizophrenia at the time, so you kind of had to deal with it. And so this is where they actually end up getting this sort of upregulation of dopamine receptors. And so instead of having, say, a hard time initiating movement, they have too much movement happening because they're too sensitive from a dopamine standpoint. So you'd see these sort of abnormal movement patterns. They'd have this like chewing or licking motions. If you look up videos on YouTube of tardive dyskinesia, you'll get a feel for what that looks like, and it's pretty drastic when you see it. Abnormal limb movements, things like that. The problem was it's not always reversible, and very frequently patients are just kind of stuck with that at that point there. And also, because some people may mistake it for acute dystonias or extrapyramidal side effects, and actually the way we treat those actually can worsen tardive dyskinesia. So that's something that we'll talk about a little bit later and how they're treated differently. So other effects of the first generation antipsychotics include a lot of alpha-1 antagonism. So you can see postural hypotension, you can see dizziness associated with that. A lot of them have antimuscarinic effects. As we'll see. So for instance, they can get that urinary retention, they can get constipation, they can have all of those side effects associated with that. That actually, depending on the drug, can be good for the Parkinsonism-like effects, because remember how we treated, say, like the tremor associated with Parkinson's? What do we give them? You give Benadryl, because Benadryl is an antimuscarinic, right? So actually, some of these drugs have that built in to where they can help out with those extrapyramidal side effects. We'll talk about that in a moment. But it actually worsens the tardive dyskinesia. It can make it even worse in those cases there. So a lot of kind of issues where it may be good in the acute phase, but chronically may be more of a problem. This will also cause a lot of H1 receptor antagonism, so sedation and weight gain are quite common with these. And then also the cardiac effects is what I worry about a lot in terms of like if I have an overdose from these patients, because they can get things like QT prolongation, which can lead to things like torsades. Some of them have sodium channel blockade, which can lead to different types of ventricular arrhythmias. All can be pretty problematic. So the really big risk you worry about, though, one of the kind of rare things, but it's something to really be aware of with these particular drugs, is called neuroleptic malignant syndrome. Neuroleptic refers to the antipsychotic drugs. It's just another term for them. But this neuroleptic malignant syndrome, or NMS, is really good to know in terms of like, you'll probably get like a board style question on this at some point. But this is seen with agents that are very highly potent at blocking D2 receptors. And basically what they end up developing is a picture that looks very similar to serotonin syndrome, where they get hyperthermic and they have ultra mental status and their vital signs will be kind of all over the place. But the thing that really differentiates us here is they get this lead pipe rigidity, right? So that means the lead pipe, like they cannot loosen their muscles, they cannot bend their arms, their legs, they're kind of locked in. And that can be problematic because exciting the muscles there can eventually lead to muscle breakdown, can lead to rhabdomyolysis, which can clog up the kidneys, leading to renal failure. So if you ever see this in person, it's pretty dramatic, because I remember I had one patient who was having, basically his arm was basically locked in place. I'm like, just relax your arm, man, just relax. And he's like, I cannot relax my arm, it's stuck. So we'll talk about ways we can treat that as well in just a little bit, but it can be very interesting when you actually see these patients present with this stuff. So here are the list of antipsychotics here, and so the ones that I've highlighted in green are the ones that I would like you to be familiar with for testing purposes, but notice there's a lot of them. We've had many of these and again, these are old drugs. They've been around for a long, long time. Yes, ma'am?
So dystonia, is that normally just in the arm?
Not necessarily. It could be any limb is affected, but usually if you have like an dystonia due to EPS, like usually you also see like facial issues, neck muscles can be affected too, so it's not uncommon for them to like have like the tongue sticking out and kind of stuck in place, things like that for sure. But like I mentioned, that a 10-month-old, his whole back was affected there, right? So it can be different muscle groups can be affected for sure. So the tardive dyskinesia you can't fix. The acute dystonias we can absolutely treat. We'll talk about that in a moment, yeah. So anyway, the point with this slide here is I don't want you to memorize every single plus in the categories there, but the general trends is what I want you to focus on. The general thing I want you to also notice is that we're going to talk about high potency D2 blockers and low potency D2 blockers. So the two big high potency D2 blockers we have here are going to include fluphenazine and then haloperidol. If you notice here, they have like 4 pluses in the D2 receptor blockade column here, okay? They are, the more dopamine receptor blockade you have, the more likely are to cause extrapyramidal side effects, the more likely are to cause NMS to occur, okay? The low potency agents will typically have more antimuscarinic effects, they're going to have more antihistamine effects, more alpha-1 blocking effects. So for instance, like chlorpromazine or thorazine, notice here, not real high potency, not many pluses here in the D2 block, but you notice here it's antimuscarinic, anti-alpha-1, antihistamine, right? So these are going to cause more of those other ancillary side effects. So for instance, haloperidol, you may not see a whole lot of antimuscarinic effects, but you will see that more so with the chlorpromazine. The low potency agents, because they're low potency at the D2 block, receptor, also means they're less likely to cause EPS, they're less likely to cause NMS. Does that mean they have no chance to cause it? No, but they have less chance, okay? So that's the general rule of thumb between those. So if I had a question on a test that said which one of these is most likely to cause NMS, and I had chlorpromazine, thioridazine, prochlorperazine, and haloperidol, you'd be able to identify, yeah, haloperidol is the one with the biggest risk because it's the highest potency D2 blocker, okay?
So if haloperidol is like more likely to cause this extrapyramidal symptoms, why is it used to treat Tourette's?
That's a good question. Perhaps to deal with some of like the motor tics, I could imagine helping out with that to some degree by blocking those D2 receptors. I don't know enough about Tourette's to say more intelligently than that, but I imagine more for the motor symptoms than anything else, if I had to guess. Any question?
Prochlorperazine, the safest one to use out of all of them?
Not necessarily. I see compazine used quite a bit for migraines, especially like the nausea, vomiting associated with that. Remember things like promethazine and prochlorperazine, these all come from kind of the same general family, right? They all kind of came from the same phenothiazines. So I say phenothiazine, this is kind of the class I'm talking about. But like, you know, I don't know if promethazine's on this list, no, but you can kind of consider promethazine on there as well. And if you recall, when we talked about side effects, you can see with these D2 receptor blockers, like promethazine was one of those things you could also see. So promethazine can cause EPS symptoms potentially. It's a strong anticholinergic, so it's less likely, but it could still do that. Or if you recall, what other antiemetic we talked about that had D2 receptor blockade? Not Zofran. Zofran's a serotonin antagonist. Reglan, metoclopramide could do that as well. And so I talked to like a old school hem-onc pharmacist one time, and they said before Zofran came around, you'd have patients who were taking high doses of Reglan that were developing tardive dyskinesia because of this long-term D2 receptor blockade, because their chemotherapy caused so much nausea, vomiting, but they'd rather deal with the tardive dyskinesia than be nauseous and be throwing up all the time, right? So again, anything blocking D2 can have these similar effects here, so just be aware of that, okay? So everyone kind of get a good feel for this slide? Again, don't memorize how many pluses there are, but the general kind of side effect profile should be kind of understood with these agents here that I've highlighted. Anyway, this is another good slide. It's a little blurry, but I think it's still pretty effective. We'll talk about the atypicals or the second generation drugs in a little bit, but this is good for looking at kind of the relative risk of the side effects. So for instance, you can see here things like thioridazine or chlorpromazine, high risk of sedation, but moderate to low risk for EPS, versus haloperidol, relatively low sedation, but pretty high risk for EPS. And it has to go back to the balance between antimuscarinic effects and the potency of the D2 receptors, okay? So kind of get a general feel for that based on the medications we mentioned that I wanted you to be familiar with, okay? Okay, so the first generation drugs really good for acute positive symptoms. So like I mentioned, like that patient who's having that one episode where we knocked him out with chemical sedation, right? That's where we use haloperidol. Who knows, was he having schizophrenia issues, positive symptoms? Was he just having a manic episode related to bipolar disorder? Sometimes you can't tell the difference, and so you still need to knock them down, and this is where things like haloperidol can come into place. You'll see that used quite a bit in like the ER setting to help sedate patients, usually giving it with a benzo or something, so that way they can just sleep it off. They don't really have any respiratory depression, and they can be much more agreeable when they are asleep, right? Again, you always want to consider the fact that you're documenting really well anytime you're giving chemical sedation to these patients, because you know, you don't want to be like sedating patients against their will, but if they're a potential danger, you can document that, and it makes more sense why you did what you did, right? You can't just like, I'm going to sedate this patient because they're being a pain in the butt. Not a good reason to do that, right? But if they're like, I thought they were going to hit me, then that could be a reason. So anyway, due to the side effect profile, this is a big reason for patients to discontinue it, but we'll be selecting agents based on their symptomatology. So if they're having a lot of those positive symptoms, maybe a more high potency D2 blocker is a better agent there versus where if you're seeing more cognitive negative effects, maybe using a low potency agent there. But overall, not great. So we'll talk about the second generation agents and how they kind of help out with this whole issue of the negative and cognitive symptoms in a minute. But how do we treat the side effects, right? So this is the important thing. So for the EPS, including acute dystonic reactions, including that akathisia, we will actually give them an anticholinergic. So that baby that came in, that 10-month-old, we were able to give them diphenhydramine, and that actually helps to restore the balance between dopamine and acetylcholine and allows those muscles to relax, okay? So you'd give these patients diphenhydramine, or you could use trihexyphenidyl, benztropine. Any of these would be totally fine. Remember, these are the same ones that we would use for patients to have tremor related to Parkinson's, right? Again, chemically speaking, they're kind of doing the same thing in terms of their effects on dopamine and acetylcholine, right? So these can be used pretty frequently. If that still doesn't work, then oftentimes we'll give a benzodiazepine as a muscle relaxant that can help out. So diazepam, midazolam, any of those are fine. For the tardive dyskinesia, there's actually not a lot you can do about that. The ideal thing would be to avoid anticholinergics, because that can actually worsen the effects. So you maybe would rather stick with like a more high potency D2 blocker there that has less anticholinergic effects. Ideally, you'd like to be able to discontinue treatment, but that may not always be possible for these patients here. So this is happening less commonly nowadays because most patients have been moved over to second generation agents. That's ultimately the best thing for them. When I say drug holiday, what does that mean? Yeah, it's hopefully not what you guys are going to do during spring break, right? Just kidding. Just kidding. You guys are the good kids, right? Just kidding. Yeah, so basically you'd say you'd give them breaks off of the medication there. So the idea is going to release some of that pressure over time. But again, it would not be a true fix for that. A lot of that tardive dyskinesia, once it happened, was not really all that reversible. So that was kind of a problem there. In terms of NMS, how we treat that, the best thing to do is, one, stop giving the agent, right? And then the next thing would be to cool the patient down and keep them hydrated. So as I mentioned, just like with serotonin syndrome, you can use cooled IV fluids, you can use evaporative cooling technique, sometimes you can even dunk them in an ice bath. We've done that before. So it just depends on how hyperthermic they are and how rapidly you need to get that back down. The other big treatment, and this is actually the treatment of choice for this, is called dantrolene, or Dantrium, and this actually helps to relax those peripheral skeletal muscles, help them to stop contracting, and then will allow them to decrease that risk for rhabdo and all of that. Other big thing you'll see dantrolene being used for is for something called malignant hyperthermia. This is something you may see used if you work in the surgical setting or maybe in the ER. This is something you may see as a result of the use of like inhaled anesthetics, or there's a paralytic called succinylcholine that can cause this as well. So you may even have like a malignant hyperthermia cart in those areas where it actually has like a little, the one we have at Nemours has like a little mini fridge built into it that has a bunch of bags of IV fluid. They'll have a drawer full of dantrolene, and then we have another drawer full of sodium bicarb. Anyone know why we keep the bicarb in there? These patients will get really acidotic as well because, again, the muscles are overworking. You burn through your ATP stores, you switch over to anaerobic metabolism, and that's where you end up seeing a lot of that lactic acidosis that can develop, right? Another thing we could do potentially for NMS specifically is called bromocriptine. We've mentioned this before in terms of being used for as a D2 agonist to replace missing dopamine in Parkinson's patients. You can do the same thing here. Helps to restore more dopamine activity, right? Kind of kicks off the antipsychotic on the receptor and kind of restores normal activity. So this is a good slide to go back to and kind of reference to see how you would treat these individual side effects and kind of what their features are like. I'm not going to belabor the points because I've already went over them, but you can kind of see how to manage those as well. So at least be aware of that for testing purposes for sure, but you'll certainly see patients who may be presenting with these. Okay, so then switching gears and getting into second generation agents, these are also known as your atypical antipsychotics. These are really supplanted the first gen and are being used much, much more commonly nowadays. The nice thing here is they lack a lot of the extrapyramidal side effects, they lack a lot of the prolactin effects, and they're also going to be less likely to cause tardive dyskinesia. So you mitigate the risk of a lot of the side effects of the first generation agents. Additionally, these are also, while they'll help out with positive symptoms, they also help out with the cognitive and negative symptoms additionally, because they have this kind of novel mechanism as compared to the first gen agents. These generally should be used as first line unless there's some contraindication to it. So the reason why they don't cause many of those side effects has to do with the fact that they have much less affinity for the D2 receptor, but what they do have affinity for is blocking this 5-HT2 receptor in the frontal cortex. And basically this helps out with the mesocortical dopamine pathway. And again, I'm not going to get super specific in the weeds on that. The main point being is it helps to fix the dopamine underactivity in the frontal cortex, and it also helps to ultimately decrease overactivity in the nucleus accumbens. So you're kind of re-regulating everything, hopefully back to somewhat normal levels. through the use of serotonin. So it seems kind of counterintuitive, like, why I'm blocking a serotonin receptor, but it's helping out dopamine transmission. But again, you have to think about different effects on these neurons based on the receptors that are present. So the slide can sometimes get a little busy, but the main thing I want you to focus on, here's this nucleus accumbens where you have a lot of dopamine overactivity. This is where a lot of positive symptoms come from. And here you have underactivity causing a lot of the cognitive symptoms up here in the frontal cortex. This is what we're targeting with the second-gen agents here. Basically, by blocking these receptors here, you end up kind of re-regulating how everything's flowing, such that you're going to have, you're going to decrease the positive symptoms. You're also going to help bring back those negative symptoms. You're going to be able to help treat those as well. Okay. So what are the adverse effects? And certainly there are many with these second-gen agents. They're just different than the first-gen ones. Most often you're going to see metabolic effects here. So for instance, weight gain tends to be pretty significant, especially with things like olanzapine and clozapine. I'll show you a full list of these in just a moment. Typically this will be lowest with agents like ziprasidone or aripiprazole. Aripiprazole is probably one of the most common ones you will see being used. And keep in mind, it's not just for schizophrenic patients. You'll see it being added on for things like treatment-resistant depression, bipolar disorder. There's a host of mental health issues you may see these second-gen agents actually being used for. Okay. Typically, if your patient gets more than a 5% weight gain, they recommend discontinuing and switching over to a different agent. Okay. So if they're on olanzapine, and again, I've seen this before in patients, they'll balloon up like 20, 30 pounds in the course of not very long. But sometimes that's the only agent that actually controls their symptoms, and so it can be kind of problematic when that's really effective for what it does, but they're also putting on a lot of weight associated with that. Yes, sir.
Is it the appetite that's doing it, or is
I'm not sure if it's just appetite necessarily, but maybe, I don't know the full mechanism for it, to be honest. I never looked much farther than that, but it could be related to appetite, it could be related to activity as well, being, because a lot of these are also fairly sedating, so maybe you're not as active anymore. It could be a lot of issues there. Yeah. Also, things like hyperlipidemia can be worsened, glucose intolerance, so new onset diabetes has been reported in patients taking clozapine before, so a lot of issues in terms of metabolic effects. Clozapine is one that's going to be reserved and not used unless they've kind of failed a lot of other agents, mainly because there's a risk for it causing agranulocytosis, which can lead to infection and death. And so there's actually like a REMS program set up for it, just like you would have for something like Accutane, where the patients have to come back and get routine CBCs being done to make sure their granulocyte count stays within range there. In general, as a class, they also tend to prolong QT intervals, so you would want to be careful. Say if you mix this with something like citalopram, you can see synergistic increases there and risk for torsades, right? How would you treat that? Magnesium, absolutely good. What type of magnesium? Sulfate. I had a student one time put magnesium hydroxide as a treatment for torsades. And I'm like, no, that'll make them poop, but it's not going to necessarily fix their torsades. IV mag sulfate is what we're going to use there. And you'll see some orthostatic hypotension related to these as well. This is a problem for elderly patients, and I'll talk about a black box warning for these in just a moment here. This will tend to improve over time though, so they will kind of get used to those effects over the course of say 2 to 3 months, and that should improve. So the black box warning though is for actually using this for elderly patients for say dementia-related psychosis, right? So let's say for instance you have grandma or grandpa, they're going into the hospital for whatever reason, and the sun's starting to go down, they're in the hospital. What kind of happens to them? They start sundowning, right? What is sundowning? They get really agitated, right? They're in an unfamiliar environment. They may not recognize people, family members, things like that. It appears to be this dementia-related psychosis that can develop there. It can be pretty significant, right? But you can see this in other elderly patients as well, not just those that are coming into the hospital, right? Some of these symptoms look a lot like these kind of manic symptoms or these kind of positive symptoms you see with schizophrenia. And so providers would use this to help decrease that agitation, that anxiety, by using these antipsychotics. And what they actually found was there's increased mortality when he did that, and so that brought about that black box warning. So if you had like an elderly patient who's getting really acutely agitated in the hospital, you do not want to use these, because then if they died, then that would be on you, and there's a big black box warning, and so that's your fault, right? So one thing to be aware of. In terms of sedation, this is pretty frequent with this group of drugs here, so especially things like quetiapine, olanzapine, which is why frequently you'll dose them at nighttime. That can kind of help out, and maybe if they have insomnia related to their schizophrenia too, that can also help out. Many of these will have anticholinergic effects, so be aware of that. Things like dry mouth, constipation can be quite common as well. Some of these have a tendency to decrease the seizure threshold, so you want to be cautious with that in patients who have a history of seizure disorder. More often than not, clozapine and olanzapine are going to be more likely to do that. Overall, I'm kind of noticing a trend here. Olanzapine and clozapine, kind of bad actors, probably clozapine being the worst one because of the agranulocytosis. So typically used for patients who have failed other agents first. In terms of drug interactions, though, the main thing you're going to find is that when you're mixing these other medications, you'll find pharmacodynamic interactions such as more sedation, weight gain, orthostatic hypotension. All those effects tend to be enhanced when you're mixing with other meds that do the same thing. And then beware if you add this with any other dopamine blockers like Reglan, like promethazine, you can increase your risk for EPS. The second-gen agents are much less likely to cause EPS, but if you start mixing with other dopamine blockers, yeah, the risk goes up. So here's a list of ones here. This is actually not the full list. This is a pretty hot category for drug companies bring out new ones all the time. I'm seeing a lot more of these starting to come out. But this is a pretty good representative list of the common ones you're going to run into. Again, I don't care that you know each of the asterisks that's in each of these boxes here, but get a general feel for ones that are more likely to cause some of these side effects. So for instance, like olanzapine causes a lot of weight gain, right? It causes the hyperprolactinemia, potentially is a higher risk than some of the other ones here. And actually I just looked this up the other day because I had a question, but the 3 most common second-gen agents on the top 200 drug list of all prescriptions in the US, actually Abilify was first, gets used most common, and it kind of makes sense because if you look at the side effect profile, it looks pretty favorable. Risperidone was probably second, and then I think quetiapine was third, right? So these are probably the most common ones you run into, but certainly if patients have failed other ones, maybe you consider using clozapine, maybe you consider olanzapine in those cases there. And again, looking at just another comparison, looking at the side effect profile here, you notice, again, much improved over the first generation agents, but there's still some risk for these to occur, right? So in terms of monitoring, most of you are looking for things like weight. You're looking at their vital signs, making sure their blood pressure is not going up, making sure you're looking at their glucose and their lipids because of that. And obviously you want to be wary of any other antipsychotic side effects. So if they're experiencing EPS, maybe they happen to be pretty sensitive to that. Those are things you want to be watching for. So as mentioned, for acute treatment for these patients here, the biggest thing is to try to get them, if they're having acute positive symptoms, get those under control first. A lot of times, as I mentioned, you may need to use a combination therapy where, for instance, you may use something like haloperidol plus a benzodiazepine to help sedate the patient to calm them down a little bit. Generally, you want to try to start low and titrate up based on side effect profile and see how they're responding to it. And if they're not really getting any beneficial effects within 3 to 4 weeks, then you can consider switching over to a different agent. Just because they fail something like quetiapine doesn't mean they're going to fail aripiprazole, right? So you can switch within classes there, and that's no problem. For patients that may have compliance issues, this is where those depot forms come up here. Keep in mind, this is not the thing you'd start with, right? Because you wouldn't just inject this into a patient not knowing what kind of side effects they're going to have from the drug or even if it's going to be effective, because once that's in there, then it's stuck there, right? So this would be something where you'd maybe have them stable on oral dosing for a while, but you're still worried about compliance, then you can switch them over to the injectable form, potentially. I'm starting to see a lot more ziprasidone or Geodon being used in the ER setting in a lot of cases here as an alternative to haloperidol because it helps to mitigate some of those EPS symptoms, so it may be something you see occasionally. For maintenance therapy, again, if patients feel like they're pretty stable and they can discontinue use, I'd probably recommend titrating off slowly, maybe over 2 or more weeks, so that way they don't have acute recurrence of symptoms. They can get that kind of rebound effects there. And then if you're switching agents, make sure you don't just like stop one day and then start the next one full dose. You want to usually kind of titrate down the first one, and then you're gradually titrating up on the dose on the second one there, so that way they don't have withdrawal effects, but you also don't kind of overload them with too much activity. So any questions on those? All right, see how far I can get into our anxiolytics. I'm a little nervous about running out of time, so no. So in terms of anxiety disorders, there's a lot of different varieties here. You know, there are patients who will have kind of chronic anxiety issues. Some of them may have more intermittent anxiety issues. Some of it may be performance related. Certainly there's a lot of varieties here. We'll talk about how we kind of manage these because they're mostly pretty similar for the most part. In terms of pathophysiology of stress or anxiety, you know, this is an adaptive response, it's a normal response, right? So being stressed out is good if there's a stressor in front of you, because if you need to run away from an animal or something, like that's a good response. These patients have a maladaptive process where they're kind of maybe chronically in some cases, just always stressed about something. I always feel like something's not being done, or they're just worried about something, right? Like I have a Pharm test coming up in a couple of weeks. can't even think about enjoying spring break because I'm so worried about the Pharm test, right? I've heard that before, right? Anyway, but be aware there's a lot of drugs that can actually induce anxiety. So it's important to look for things that could be leading up to these symptoms here. It could be exacerbating underlying anxiety. So for instance, akathisia kind of looks like they're anxious, right? Things like stimulants or sympathomimetics. If you take too much caffeine, guess what? You may get pretty anxious, right? And so also you're going to find that drug withdrawal in some cases can lead to anxiety. So if they're alcoholics or if they are on benzos or opioids chronically and they're coming off, they may be presenting with anxiety. So a lot of drug related reasons you at least want to be familiar with. In terms of treatment, we're going to focus on the pharmacotherapy. For acute anxiety symptoms, typically benzodiazepines are going to be your go-to here, right? For more chronic management, actually our antidepressants are going to be playing a big role. So typically depression and anxiety go hand in hand in a lot of cases, and sometimes patients who may appear to be depressed, actually they're just really anxious, and that's causing a lot of their depressive symptoms. So it depends on how they're presenting. We'll look at a few alternative agents we can also use as well in just a bit. So in terms of our antidepressants, typically we're going to start off with SSRIs. First off, certainly SNRIs could also be used. You may find due to the norepinephrine effect, some patients may actually have their anxiety worsened by SNRIs. That may not be appropriate for everyone. But typically for kind of long-term chronic, generalized anxiety disorders, antidepressants are going to be good to help kind of shave off that anxiety. It's kind of like, you just care a little bit less. You're kind of like, whatever, no big deal. It's kind of the effects I hear with patients. They just say, yeah, I got that test coming up, but whatever. It'll happen when it happens, right? So that's kind of the effect you get from those SSRIs. TCAs you're going to use less often, mainly due to side effect profiles, but could be a backup potentially. So in terms of how they work, we really are not sure, but we do know that it's certainly effective over the course of a few weeks, very similar to how we see that it works for depression. So the benzos, remember how benzos work, right? So they work on which channel? GABA D? GABA A, right? So they work in GABA A channels. Remember, when you activate them, right, they help GABA to bind more easily, right? They help, they cause a conformational change that allow for GABA to bind more readily, and they allow chloride to flow in. So these are good for acute anxiety sort of symptoms. Patients may have like an as-needed prescription. So say if you're having anxiety, if you're having a panic attack, use a benzodiazepine. Some patients will be on this more chronically, say around the clock potentially. There's a lot of them that are out there. We covered many of them that you may use for seizure disorders, but here are some more that you're going to see being used for more general anxiety sort of issues. So certainly things like alprazolam is quite common. Clonazepam I see quite a bit of use of. You'll notice here that I have a few of these that are starred, right? So obviously if I star them, that means what? You should probably know something about them, right? So the main reason why I star these is because a lot of these benzodiazepines, depending on the agent, some are more lipophilic than others, some are more hydrophilic, some have active metabolites. This can be a problem for elderly patients, right? Have I talked about the Beers list before? The Beers list? No, so the Beers list is a list. It's not like when you go to the pub and see what's on there. But the Beers list is basically a list of medications that are particularly dangerous to use in elderly patients due to their propensity to cause side effects. Anticholinergics are on those lists. Opioids may be on there. Benzos frequently are on there as well because as patients get older, guess what happens to organ function? It's going to get worse, right? So for instance, if I have a patient with poor liver function, they may not be able to process these benzos quite so well. They'll accumulate levels, and thus they can lead to toxicity, right? Or for instance, if a patient's not able to clear it very well, but they're very high lipophilic, right? What happens to the levels in the body of lipophilic drugs? They build up over time and they may stick around for quite some time. So the ones that are safer for elderly patients here are what I call the LOTT benzos. So it's LOTT. So it's lorazepam, oxazepam, temazepam, and then triazolam. These are four that tend to be more water soluble. They tend to not be very lipophilic, so they don't accumulate very much in the body. They don't have active metabolites, meaning they don't have byproducts that are also active as benzos, and they are able to be cleared through the kidneys. Okay, so these are safer in elderly patients because they're less likely to accumulate and cause excessive drowsiness, falls, things like that, right? So those are the four that are better for elderly patients. LOTT. Yes, ma'am. So they're more hydrophilic, so they can be cleared easier through the kidneys because they don't accumulate in the fat as much. They also don't have active metabolites. Those are two big reasons there. Yep. And again, we know benzos can be used for lots of other things, so acute agitation, as a muscle relaxant, for sedation, for sleep, for seizures. A lot of uses for the benzos here, but here we're using them specifically for anxiety. So again, looking at the pharmacokinetics, they're quite variable depending on the agent there. Also, short half-lives are also what makes those benzos nice for elderly patients, because again, they don't stick around for as long. So just be aware of as well that some of them are going to metabolize through CYP3A4, so they may have interactions if you have an inducer or an inhibitor on board that could be causing the effects to be more pronounced, right? So typically for outpatient use, a lot of these patients will have oral prescriptions available for them for benzos. For like acute agitation, if they present to the ER or something, typically will go more IV, IM for those patients there as well, right? So in terms of adverse effects, we know that sedation is obviously the biggest thing here, right? So it's kind of like just being drunk. So again, sedation, dizziness, ataxia, all those things are pretty common with these ones here. May see memory impairment as well. Could be another big thing you want to watch for. Have I talked about the paradoxical excitation you can see with benzos? I know I've mentioned that with antihistamines before, like Benadryl, but this is more something you see in kids quite frequently, where you basically give them a dose of a benzo and they actually get hyperagitated, bouncing off the walls essentially. It's rare, but you may see it occasionally. Some patients just don't do well with benzos. Sometimes you can actually give a bigger dose and that kind of overcomes that, and they will become sedate. So just be aware. And also these will mix. They will have synergistic effects with alcohol, so you have to be really careful to make sure patients are not taking the two together. You'll see pretty significant sedation associated with that, okay? Remember, withdrawal from benzos can be quite severe, right? What's the worst thing I'm worried about with the benzo withdrawal? Seizures, right? Because again, your body's used to having a GABA around all the time. If you're losing that, be cautious. So if they're taking it chronically, you have to make sure that if they want to come off of it, they have to titrate down over the course of a couple weeks, right? As an alternative, let's say you had a patient who had a substance abuse history and you did not want to give them a benzo. This is where we can actually use an alternative. It's called buspirone or Buspar. This is going to be nice. It's not an anticonvulsant. It's not going to have any. It's not a controlled substance like the benzos are, but it could be, and probably not quite as effective as something like a benzo might be. But it can be used for more long-term management of anxiety. It does take a few weeks to kick in, but if you had a patient again who benzos are not a good option, maybe starting them on Buspar might be a good alternative for them. Knowing the full mechanism, it probably has something to do with some serotonin agonism sort of effects there, but potentially you could actually use this along with an antidepressant potentially. So again, you could use that as an add-on sort of agent to help out with that anxiety. Again, it's metabolized through CYP3A4, so be cautious if you have any interacting drugs there. Now, beta blockers. Why would I use beta blockers for anxiety? That makes sense? Okay, so yeah, so what are the physical manifestations of anxiety? Tachycardia, what else? You get tremors, what else? You get nice and dry, you're sweating, right? So giving a beta blocker is useful because this helps to mitigate a lot of the physical effects of anxiety. You'll still be anxious, but you may not feel as anxious because you don't have that tremor, you don't have all that sweating and the heart rate going up. So for instance, if say you had a presentation you would have to give. So say I were to call you up here and give a presentation right now, some of you might be anxious, right? Because you're like, I don't even know what these slides mean half the time. Like, I'm not good at public speaking, whatever the case may be. You'd be pretty anxious. If I were to give you a benzo, how well do you think your public speaking would go? Not great, because all of a sudden you start slurring your speech and you fall asleep halfway through. Not great, right? So because of the sedating effects of the benzos, we don't necessarily like that for performance anxiety, so to speak. However, if I give you a beta blocker, much less likely to cause that. It deals with the physical manifestations of anxiety, and it's not really going to cloud your mind all that too much, okay? So that's why we end up using it for things like, musical performances or public speaking engagements, anything like that. I had a class in pharmacy school. It's called pharmacotherapy. I don't know if I've mentioned this class before, but basically we had a class of 50, all of us in a big auditorium, and we'd have like a facilitator in the front of the room. They were an expert in whatever we were talking about, whether it's cardiology or neurology or whatever. And so basically at random, you get called on to stand up, and you and your team would come up with a plan for this patient case you had gotten, and you had to sit there and verbally defend your plan with an expert, and I'm a student, I don't know what I'm talking about, they know all of what they're talking about, and so it was a pretty stressful sort of environment there. And so some fellow students, they were like, yeah, it's not a big deal, I just take a beta blocker beforehand, I'm good to go. And I'm like, you do what? They take a beta blocker beforehand. I was just like, that's performance enhancing drugs. They're getting a better grade because they're using drugs and I'm not. So I'm still a little salty about that, but I learned to get over it just by repeated exposure, so now I don't really care about speaking in public. Regardless though, so one of the big things though to make sure your patients do is to do a test dose beforehand. You don't want them to take a beta blocker and all of a sudden get up and they pass out because they had orthostatic hypotension, right? So see how they're going to respond to it first before the event, and that way they can then take an hour beforehand and they'll be good to go, right? So this is another a common thing you may see. Used probably not for say around the clock use, but used intermittently for whenever those performances are. Yes, sir.
Are there any side effects with an amphetamine? Someone's going to take Adderall and then
Okay, so Adderall, we'll talk about those a little bit later in the section, but what are sort of the effects of Adderall? What did you expect to see? So you see lost appetite. What other things is? Tachycardia, hypertension, excitation, maybe anxiety. You can see anxiety with those, right? So beta blockers could mitigate some of that stuff. And in fact, I've had patients who come in after doing a large amount of amphetamines, methamphetamine, and we actually have to give them potentially something like a beta blocker to help get their vital signs under control. So yeah, they usually are antagonistic to one another. Well, it may not necessarily change like the alertness sort of aspects of it, but it will deal with the physical side effects potentially. Yeah. Anyway, so let me finish up this section real quick. So in general, if they're having acute anxiety issues, panic issues, like this is where benzos are going to be playing a big role here to kind of get those under control acutely. And then you can start them off an SSRI or SNRI. If it's more performance-based, that's where beta blockers are going to be coming into play for the most part. Remember, all the same caveats apply with that. So if they're asthmatic, like you probably don't want to use a non-selective beta blocker. You know which ones you can use in those cases there, right? If they're still not getting adequate responses with more chronic SSRI therapy, consider a TCA, but just be aware of the side effect profiles there. Right? Any questions on that? How many slides do I have left? And too many for today. We'll finish it up next time. Let's see. How long do the effects of the beta blocker last for anxiety symptoms? That depends on the duration of action for the beta blocker itself. So it could be 6 to 12 hours potentially, or I wouldn't use a long-acting beta blocker necessarily, like a Toprol XL. It's an extended release, but as long as the beta blocker would normally last for other things. So, any other questions? If not, I will see you next week.